We won't quite go there. But welcome all, one and all and sundry, to the 73rd, believe it or not, episode session of MRF HIV STI Echo. Thank you so much for joining us and keeping our little family going. Our family of learners or family of enthusiastic persons who are supporting persons living with HIV all over Trinidad and Tobago. As per usual, I am Dr. Gregory Boyce. We are facilitator for the afternoon. Conrad is our worthy coordinator who has disappeared behind the iTech logo, probably take care of his dog, but we love them both. And welcome everyone. So today's session came out of a presentation that Sharon had actually given to iTech, just to outline the psychosocial program at MRFTT and how it delivers a differentiated care model to some of our most challenging patients at the Medical Research Foundation in terms of achieving viral suppression and looking differently in how we provide service. You know, when I was trained as a doctor, my idea of a clinic was doctor, desk, file, patient, nurse somewhere in the back taking bloods and doing blood pressures, and that was a clinic. That's all it needed to do, right? But as we have learned over the years, especially in a field like HIV, when there's so many impingements on the ability of someone living with HIV to manage themselves, to manage their disease, we now are being educated into things about differentiated care models and non-medicalizing treatment of HIV. And I think the psychosocial team at MRF was put together primarily for this purpose, and I think it's doing excellent work. So with all that being said, I will turn over to Nurse Sharon Soyer, who will run through with us the functioning and some of the early outputs of the psychosocial program. So let me just start sharing, and over to you, Sharon.
Thank you. Good afternoon. Congratulations on your 73rd anniversary, as it were. Right. My pleasure to be here to present on behalf of the psychosocial team our psychosocial program as a model of differentiated care at MRF. So I hope you have a good session, and I'm able to impart some of the information, on what we are doing in the psychosocial program. So this at the Medical Research Foundation, the psychosocial program was launched in January of this year, and we consider it to be a model of differentiated care. So a little of the history of MRF. So the Medical Research Foundation was founded by the late Professor Courtney Bartholomew in 1997, and it was started as a need for local, regional, international research, and that continued for many, many years, leading up to 2002, when Professor was asked to start by the government of the day to start the treatment and care of HIV for persons living with HIV in Trinidad and Tobago. The following 15 or so years was really spent, building the core of the services, the infrastructure, the education of the staff, getting supplies, the laboratory, medications. So a lot of that core infrastructure and services, took place in the years following 2002. In 2017, Dr. Edwards took over from Professor when Professor retired as a new director, and under Dr. Edwards's purview, faced with a large clinic population, new approaches, new strategies were implemented, and one of those being differentiated care, that model of using differentiated care programs. So the psychosocial program is one such program that we'll be talking about today. So just a bit of background, this year actually makes it 20 years that MRF as a treatment and care center. We celebrated our 20th anniversary this year. Is the largest single HIV treatment clinic in the English-speaking Caribbean. Our total enrollment as of today, because I checked it today, we like to be very up to date with our statistics. So we have 10,196 clients enrolled, and again, this was checked today. Active in care is 5,126 clients. We have approximately 2,000 clients who are very likely live but may have defaulted, and that's a separate program where there are programs working on getting them back into care. our adherence to antiretroviral therapy is at 90 and possibly a little higher than 90%, which is actually an excellent achievement. And as the Medical Research Foundation, we are striving towards the new UN goal of 95, 95, 95, which is 95% of persons who are HIV positive need to know their status. Of that, 95% of those need to start on antiretroviral therapy. And of that set, 95% of those persons need to be virally suppressed. So what is differentiated care? The International AIDS Society defines differentiated care as a client-centered approach that simplifies and adapts HIV services across the clinical cascade to reflect the preferences and expectations of various groups of people living with HIV, while reducing unnecessary burdens on the health system. So what this means simply, and I'm coming back, and I'm just reflecting on what the clinic was before, when we just had one large clinic delivering one suite of services. As time goes by, what you realize is that in order to best meet the different needs of clients, different programs specifically designed to meet those needs have to be designed. At MRF, we do data-driven decisions. So to make decisions about whether or not a differentiated care service is needed, that is where those decisions come from, is based on research data that is driven from our clinic population, right? You see, I have a picture of a bank. So an example of, I have two examples to give of differentiated care that we can make it simple to understand. So when you go to the bank, everybody goes to the bank and you go to the front door. Let's say you go to the front door of the bank. Everybody entering that front door has a need. They have a need for banking service, right? But when you get into the bank, you may need to go to the teller, you may need to go to loans, you may need to get a new updated chip card. You understand? So therefore you are diverted to different lines. And therefore, even though, like for our patients, for example, while all of them might be HIV positive, their needs though may not be the same. And therefore differentiated care programs identify and streamline clients based on the needs. As I was doing this, I remember that SEA results are coming out tomorrow, please God. And when I thought about it, I said, SEA exam is the same thing. They use a differentiated model to determine where children get streamlined to go to school, because all children would not perform at the same level. There are children who might be, technically or vocationally talented. There are some who might be academically talented. There are some who may have challenges. And therefore, if in Standard 5, all students were to go straight from Standard 5 into a same Form 1 class and continue, there will be a lot of fallout. And that is why, for example, you have different tiers of schools, because what is happening there is actually service is being provided to meet the need of the person. So for the students who might need, to go at a slower pace, for example, there are schools that meet those needs. There are schools that need children who might be more technically savvy and so on. So it's just an example to say differentiated care is not a new model to health. It's used in many, many different sectors all over. So it's that MRF is undertaken using the concept, the model of differentiated care to provide care for all our clients at MRF. In that previous note, there was the mention of the HIV Clinical Cascade. So the HIV Clinical Treatment Cascade is a model that outlines the steps of care that people living with HIV go through from initial diagnosis to achieving viral suppression. And usually it shows the proportion of individuals living with HIV engaged at each stage. So said simply, it starts at a point, it's a way of representing where clients are along the continuum. So for example, when a client is just diagnosed, they join care, then they have just diagnosed, they are referred to care, they come in to join care, they start on treatment, they have to remain on treatment, and the aim is that they remain virally suppressed, right? So what the HIV Clinical Cascade does, if you think about it, for every client, it's breaking down the steps. And at every point, there are challenges that a client may face that may prevent them from being fully engaged or, meeting their needs. And therefore, at each stage of that cascade, when it's broken down that way, it means that programs and so on need to be developed to look at each point along that continuum. So at MRF, we have different differentiated programs that are actually going on right now. So for example, we have the youth program, the youth program when you have the young persons who are 24 years and under, because again, their needs were identified as being different from the general clinic population, right? Because young people have a suite of concerns that need specifically to be addressed. So men's health, for example, based on data, it was realized that men need specific attention. They need a forum, to be able to express their concerns, different kinds of investigations that might be warranted. Same for women's health, so that you identify what is the need that this clinic has. So all clients coming in, sometimes clients may even participate in more than one program, right? But the idea is identifying a suite, just like the secondary school or the bank, where you have specific areas where persons may be channeled. That's the whole premise of the differentiated programs at MRF. So the psychosocial program is one such program, and this came out of a need for realizing the need for a suite of psychosocial services to enhance what was currently being done. I have the EASP, which I will talk about a little later on the far end, but also as part of the psychosocial program. But what I just wanted to demonstrate with this picture, and of course, if you notice, the block that the guys they are building is stronger together than one block alone. And it's the same thing. When all of these programs come together, you find that the services that we are offering to clients will be better, will be stronger, will be programs that meet clients at the point of their need. So the MRF Psychosocial Program. The goal of the MRF Psychosocial Program is to identify and address the psychosocial needs of clients and to improve the quality of life outcomes across the HIV continuum. And the psychosocial team at MRF. So once the psychosocial team came together, and I do have to say that although we have pretty much, we've started to plateau from January to now, this is where we are from, and in this point of our journey, but we always have rooms for new ideas, new initiatives and so on. So who makes up our team at the Medical Research Foundation? It is comprised of a team comprising of peer counselors. We have 2 peer counselors, 2 social workers, a psychiatrist, a clinical psychologist. The doctor is on the background because the doctor, I think, is supporting throughout. We have our client as our center focus. And although I am the program coordinator for that program, I am not on the chart, but I consider myself to be the orange line that's joining all the parts together, because that's my role, to pull it together and help it to run effectively. So to just let everyone know who are the persons on our team, we have Mr. Wayne Jackman, who is our peer counselor. I don't think Wayne is here today, but Wayne comes with a background with some training in social work, substance abuse, poverty, homelessness, right? So he works with clients, especially with those types of needs. Mr. Dion Gill, our other peer counselor, very efficient, he's doing his master's in counseling, works especially with the MSM community, and does a whole lot of training, especially so really supports what we call our buddy program at MRF for new clients and getting clients in care. And both gentlemen work very much in the community, and that's an important aspect. So it's not just in MRF and in the services that you're getting within MRF, but a lot of what they do is that reach out into the community. Sometimes they're both contacted by persons, for example, who have fallen out of care and need to come back in, and so we're very much appreciative of having the peer counselors as part of the psychosocial program at MRF. We also have Mr. Lyndon Gums, who's a psychiatric trained social worker. so I should say trained psychiatric social worker, and with a background in, he's also a diabetes educator, right? And Mrs. Wendy Samaru Francis, a medical social worker, again, lots of experience in GBV training, research, right? Mrs. Patricia Lewa Cooper is our clinical psychologist. Professor Gerard Hutchinson joined us as part of the team as our psychiatrist. As I said, I'm the program coordinator, and we are, of course, appreciative of having Dr. Boyce as a physician on the team.
Sorry.
That's okay. Yes, I believe so. So to talk a bit about our peer counselors and what have the peer counselors been doing at MRF. So we looked at some data from January to May of this year, and as I said, the psychosocial program started in January of this year. And our peer counselors collectively saw 145 clients. Notably, they see clients who are referred to them. So 94 of the clients whom they saw were actually clients in care, and it meant that those 94 clients, a challenge was identified by a staff. It may have been a doctor, a nurse, a social worker, and they realized, well, okay, this client is well, the client is doing okay, even perhaps with a virally suppressed, but this client is having other challenges. So, for example, this client may be struggling with sexuality or having a substance use problem, and therefore those clients are referred. So they are in care, but they are referred to the peer counselors. Some clients who have defaulted and have returned to care are also seen by the peer counselors, and they use that opportunity to find out from them, what prompted them to default from care. Some of the feedback that I've had, for example, is that sometimes a client may not have any support person. They have no one who knows what's going on, and therefore the peer counselors would link with them and use, and when you come to some of the strategies, we'll see later that they use in order to provide them with that kind of support. They also have started seeing our new clients in something that we've been calling the buddy system. What we realized is that new clients, when they come to MRF, can experience a very isolating and fearful experience. And that experience, depending on how they interpret it, can actually lead to fallout of care. So we had some data where show that clients actually fell out of care not too long after joining clinic. So to meet that gap, the peer counselors have started working as in the buddy system. So what they do is that they engage with the client, whether it's before they come. For example, as I said, they may be contacted in the community, and they are told, someone who's tested positive, and they, escort them in. Or when the client actually comes to join, they are introduced and they walk them through that new first day experience, right? So for somebody who has come to MRI, for example, for the first day, for persons who may not know, you have to give demographic data. You have to go to the back to have bloods done. You have to come back to the front to have an interview with the nurse. You have to go back on the other side to have an interview with a doctor. You have to go on another place to wait for medication to make sure you have an appointment, right? So there are a whole lot of different things in a new environment, and it's just like the child on the first day of school that all of us would have experienced. Sometimes it can be overwhelming, it can be fearful. So having a buddy there to walk you through is very important. Making the link on that first day is equally important, because what they do in the buddy system is that they remain linked with them as time goes by, as the weeks go by, to answer questions, provide necessary information that the client may need, right? And the purpose of that program is to keep clients engaged in care beyond the 6 months. And again, that was a response out of a need where our data showed that clients were falling out of care after 6 months, and new clients were falling out of care. So we're hoping that when we evaluate some data later on, we'll see the effectiveness of the buddy program, and perhaps see where we can embellish it, and what needs to change. So our peer counselors identify, when they see clients, they identify what they believe to be the challenge that this client had been experiencing, and it's recorded under these headings. So client may have, for example, poor adherence, meaning adherence to antiretroviral medication, lack of support, meaning, they there's no one, their family have deserted them, or they haven't told anyone, and they are all alone dealing with HIV. Disclosure issues, so they may not yet have disclosed their HIV status, whether it's to a partner or to significant others. A substance abuse issue or general issues. General issues is a long, wide issues, because sometimes clients, they have, it might be a question of medication or side effects, or just general knowledge or so. So you find that that's why that general column is so high. Many clients also may have more than one presenting problem on the day. So when we are tracking the information, they write in as many. So although you see the numbers wouldn't correlate to the 145, that's because a client can present with more than one concern. So overall, we do try to put the clients who have adherence issues to talk to the peer counselors, and that has so far, just from my observation, been a useful tactic, because many times clients, they talk to the nurse and the doctor, and they say, well, you all can't really understand what I'm talking about, because you all don't have HIV, you don't have to take this tablet all the time, and so on. And the peer counselors, and I do have to say that they readily identify themselves as being HIV positive in care, on medication, and adherence to medication. And they have the conversations with the clients. And what we've found is that the clients respond very well, because they find that it's a conversation. It's not an up-down conversation, but it's a horizontal line conversation where they can share the information with somebody who's standing in that same shoe, right? So we found that that's very good. The peers do assist with disclosure issues, and I should mention that both our peers are HIV testers, so they have passed their HIV qualification test, so they are legitimate HIV testers. And that's also something very important, because for clients who, for example, to maneuver through a disclosure issue with a partner, if they get to the point where you have your partner coming in and they can disclose to the partner, then that peer counselor can follow through with the HIV test. If the person is HIV infected, then again they can just continue along the continuum, getting that said person in care and following them along. So the peer counselors have different interventions that they can undertake when they've seen a client. You notice that we have, and again, the interventions may be more than one per client. So many of the clients, we had 76 out of the 145 clients whom they had seen, at least they had requested to see 76 of those clients at a follow-up visit. And this is important because sometimes that ongoing peer support is very important. It's not as opposed to a one-off visit. You find that they do engage in counseling with clients, and we saw these 65 in such interventions between January and May of 2022. We have a phone and WhatsApp service that the peer counselors use. So when they come, whether it's on the first day or that first intervention or whenever they meet them, they share their information, of course, get their clients' permission, whether they are interested in having a WhatsApp, well, it's okay to get a WhatsApp or a phone call. There was some data, some international data that had shown clients who got phone calls or WhatsApp reminders between appointment 1 and 2 were more likely to stay in care. And again, the decisions such as these are not, they're not just made vicariously, but you decide that, okay, this data supports this. So to that end, we have the peer counselors using the phone and the WhatsApp messaging. And even for one client on any one day, it may mean multiple messages for that client. The phone messaging has been a very useful strategy when they want to give reminders. If you remember, many of the clients whom they see have adherence issues, and therefore having someone to remind you, especially if you had an adherence issue and you had no support, so it was just you alone, you had nobody to remind you, nobody to check up on you or call or even ask, did you take your medication? It's time to take your medication, you have an appointment coming, and so on. And you find that that's the role that the peer counselors have been filling in giving the patients those very important and necessary It's both reminders and also like a continued support during the visit. And when that client comes back for their following visit, if they need a face-to-face discussion, well, that is facilitated on the day. I had already mentioned the buddy system below. The peer counselors working within the SOP of MRF are required to, they are required to work within a framework. And once they determine that they have identified issues that are beyond their means, they do refer to the social workers and, if necessary, to the doctors and nurses and have communication with them. The peer counselors also started a group session to meet the need for group counseling, because as I'm sure everyone will appreciate, the need for group support, well documented, well supported. So we are working right now on strategies to sort of bolster that, to be able to have that service available. For the clients who came during these sessions, when we sort of tried it out and see how it was going, although the turnout was low, it was actually very rich in terms of the value that of discussion and sharing that took place there. We are considering bolstering it using some psychologist support and some other peers and so on. So it's one of the programs that we're looking forward to improving as the couple months to come. So if you remember, we talked about the HIV continuum a little earlier. So to put it into context, you have as I said, you have the HIV continuum, which identifies, if you think about it, per client. This is a client from the time you diagnosed, you came to join care, we need you to stay in care, you need to start medication and remain on medication and remain virally suppressed. So what have the peer counselors been doing in order to meet these needs? So for example, if we look at diagnosed, our peer counselors have completed their HIV testing competency, and they counsel clients who need assistance with disclosure, meaning they haven't disclosed their significant partner and they need assistance to do that. So by having the peer counselors, this counseling on disclosure and assisting the clients to disclose and following that up with actually being able to do the HIV test, they find that in that way they are in fact meeting the need for the clients who need to be tested to find out their diagnosis. As I was saying just now, when they come and they join clinic, the peer counselors use the buddy system so that they are engaging them, they're joining them into care one time. Because as we know, there are many persons who have been diagnosed with HIV, but they haven't been linked to care. They haven't shown up, they've been referred, but they haven't quite made it yet to the treatment site. So using the buddy system, that's the role that the peer counselors are doing in linking the clients to care. And of course, I'm getting that close case management and WhatsApp following. In order to keep the clients in care, that's when we talk about the peer counselors doing their follow-up counseling, their group supports, their phone call and their WhatsApp messaging, especially in between appointments 1 and 2. Strategies like those better keep clients in care. And some of those same strategies, again, assisting clients to remain on treatment. And strategies that the peer counselors are engaged in that assist with helping the clients remain virally suppressed. For example, that counseling and that follow-up, and participating as one of the team members in the EASP package, which we will talk about a little later in the presentation. So we're going to talk about the social workers in the psychosocial program at MRF. So from January to May this year, the social workers saw 611 clients, which is a mix of both in-person and telehealth. A large number of those clients, which was like 67% of them, were clients who were in care. And you notice that they actually saw more of the return to care clients, because what we've learned is that when clients default treatment, default clinic, and they return, inevitably a psychosocial problem may have been pressing on that individual that caused them to default from care. So it was a good point and a good point of intervention to have the social workers intervene there to be able to re-engage the client and keep them in care. And so far, they don't see as many of the new clients unless it's on a needs-be basis. But they return to care themselves because that's, I think, a very, very important component. Because if you've defaulted and you've come back in care, what we're trying to do is to keep you in care. So to the social workers, being able to identify those psychosocial challenges, getting interventions to keep them in care, I consider extremely important. The social workers also identify the challenges, just as the peers had, and a client can have more than one challenge. So we see that adherence challenges, the 310 of the clients whom they saw had adherence challenges. And again, because poor adherence is very, very often linked to psychosocial issues, that's when if you understand that, you'll understand why my that bar chart is so high, right? During COVID-19, clients experienced increase in insecurity, food insecurity, housing insecurity, transport, issues that patients really just did not have food, they did not have money to come to clinic and so on. And they do see that when they talk to the social workers will work with each client because for each client is an individualized plan of care to determine the next steps. Substance abuse, which again was shown to have increased during COVID-19. Yes, mental health issues, which sometimes undiagnosed. And that's why also, as part of that whole program, we are so happy to have our psychologists and psychiatrists to assist. If the social workers identify the need, then they are able to refer to the psychologist or the psychiatrist, right? And of course, partner issues, which can include sometimes it's not even directly related to HIV, but communication issues, that they're having, and under other, for example, they face a whole conglomeration of stuff. For example, the social workers would say you have a client whose child has died, and they're going through grief, but that grief might impact on their ability to be adherent. Also, it might be just strictly counseling relating to that grief. But they do engage in a lot of counseling and a lot of those psychosocial challenges, especially once identified by some of the staff. They are referred to the social workers, and then the social workers, why some of those numbers are so high too for that short time frame, is because they also don't do a one-off intervention with the clients. They too do follow-up with clients. So some clients, they may interact with the client even more than once during the month. The social workers in the psychosocial program identify the interventions that they undertake. And as I was saying just now, the majority of their intervention is in fact counseling, addressing the need on that day and referring the client back to the general clinic. They do also refer to their colleagues. So a social worker may refer to a peer, to a psychologist, psychiatrist, the doctor, the nurse, depending on the dynamic being played, right? They also refer to external agencies because they have clients who, for example, may be homeless, substance abuse, needing social development, social welfare, counseling, etc. And of course, they do engage in a lot of telehealth, and telehealth, came up during COVID, but it's turned out to be a very useful strategy because it's an easy, quick way to do effective follow-up without having the stress of having the client present to clinic on that particular day. One of the requirements that the psychosocial program was wanted to do, or was required to do, because this was a need that was identified through data collection amongst the staff, was the need to have PHQ screening, PHQ-9 screening. So PHQ-9 screening is a standardized screening tool that is used to identify depression. One of the things we understand is that mental health challenges are very common in HIV infected individuals. Therefore, the better way to approach managing mental health issues is to use standardized screening tools as opposed to just an impression or feeling, of referring a client on just because they have a feeling about it, or the patient looks depressed or something like that. So using standardized screening tools is one of the things that we've been able to start, for which I'm very grateful. So between February and June, because we actually started in February, we had 127 clients who were screened. And of course, in the screening tool, you are given, based on the questions and how you answer, you are given a score. And based on that score, the next intervention is determined. For clients who score over 10, they are referred to the psychologist, and the clients who score 15 and definitely 20 to 27 require, or they get an urgent review by from the social worker to the psychologist, and the next decision is made. So, for overall, we saw that so far the majority of the clients whom we've seen have none to minimal. And we had, which I thought was quite significant, some moderately severe and severe depression, even in that small group of clients. So going forward, we will determine whether we need to, whether we are going to implement annual screening for all clients, which is recommended in some circumstances, or whether it's going to be something that's much more focused. So looking at the social workers and the HIV continuum, and you ask, well, what did the social workers do to be able to meet the needs along the HIV continuum? So, for example, if we're looking at clients who need to be diagnosed and to know the HIV status, by the social workers counseling the client and encouraging partner testing, I should say we now have our oral HIV swab test, which is excellent. So it can be assisted or partially assisted. So that alone is a great option, for clients, and they're assisting the clients with disclosure. One of our social workers is an HIV tester. So just like the peer, she's in a very important position where she can counsel the client, and actually be able to, even if the person wants to get an oral swab to take home for their partner to test, and she can follow up on that client. Or I should say the follow-up on the client is actually the next bar, the gray bar, because she wants to make sure that that client is enrolled. And that's a good example. So in the first bar, where she can counsel the client, assist with disclosure, cross that bridge, give the client the oral swab, for example, how does she help in that next step in getting the client linked to care? She can follow up and find out what was the partner's result. If it's positive, get the client into care, following up using telehealth. How do the social workers assist in keeping clients retained in care? Counseling and psychosocial support, telehealth, giving referrals as necessary. And the same thing happens for keeping, once the clients start medication. And strategies that the social workers use to keep clients virally suppressed. Again, when we talk about the EASP package a little later on, counseling, telehealth, and referrals. Thank you, Ty. Our psychiatrist, as I said, we were very pleased to start having these services at least once a month from Professor Gerald Hutchinson, who's providing our psychiatrist consultant services. So the role that he's playing is to provide diagnosis and medication support for clients, both diagnosed and undiagnosed mental illness, particularly those with illness that adversely affects their ability to maintain adherence to medication. As we know, there are many persons who have mental illness but have not been diagnosed. Some of them have been, they've gotten multiple referrals, but they've not gone to the wellness treatment, the wellness clinics, for example. Many clients that I've spoken to, would say, when you ask, well, why haven't you gone? They fear stigma and discrimination at the sites. They have no one to go with them, so to bridge the gap and to be able to help this person be able to identify, get that mental health issue diagnosed, and to start on treatment, and to get that support as time continues, to be able, all of those are strategies to be able to assist this client to be able to remain on medication. And as you see my team putting things together, so of course it's a team approach. So for example, on the day when the psychiatrist is there seeing the clients, he's supported by our psychiatric social worker, who is again providing all the necessary support. Significant others, whether it's family, friends, employers, whoever that significant other is, encouraged to be part of the care. So attend the appointment with the client and be part of that, because in order for clients to also remain on medication, just like HIV medication, it's important to have significant others and to have support. And of course, that follow-up, very important. So we are also building that. We have also built that part of that follow-up support in between the psychiatrist visit and the following visit to ensure that the client is taking medication and tolerating it and so. So another member of our team is our clinical psychologist. She gave me permission to show her 2 slides. So these are her slides. So what she wanted to share, sorry, is that this was October 2021 to May 2022, she had gotten 212 new client referrals, and of that she had been able to see 155. If you understand the role of the clinical psychologist and the time involved, even for an intervention, counseling and follow-up, is also something that's very, just like the social workers, very time intensive. So you find that the burden of it is increasing. And with the staff becoming more sensitized to identifying these kinds of challenges, you find that we found that just looking, notice that the referrals have been increasing, and that's actually good because it means that the rest of the staff are also becoming, more sensitized to identifying the challenge when they see clients, recognizing there's a need for assistance and following the clients to the clinical psychologist. So she has said that 28 or 18% have benefited from at least 2 revisits. She means that she has had a chance to follow up, because for some clients, one-off visit with the psychologist will not suffice. She needs to have, it may be, for example, 5 sessions or 10 sessions, depending on what is the diagnosis and what she's helping the clients to do. If it's learning a new skill, learning a new way of dealing with an issue or a challenge, then these things need time. And the best way to do that is by having follow-up visits. Right, so she also is part of the team on that EASP package, and therefore that EASP program. And again, because you're identifying particular clients, having this psychologist even as part of the psychosocial program at MRF is just excellent. So she wanted to share too the mental health conditions that she has identified in the 6 months that she's been seeing the clients. She did note that non-adherence, out of the clients whom she had seen, 16% of them had non-adherence related to medication. Many times, actually, the client might actually be virally suppressed, but they have actual or potential stressors that if they continue on that path without an intervention, their viral load they will start default medication, and you'll notice their viral load going up. She identified 15% of clients who experienced some sort of trauma, including intimate partner violence, and she's been doing counseling and referrals related to that. Very interestingly, 63% of the clients whom she saw when she was recording the mental health conditions that she recognized, she saw 63%. And if you remember earlier when I was saying the PHQ-9 screening as a standardized tool, and looking at that information on this one, very important. And we'll look at it again in a few months to determine if, as I said, what our SOP called for was annual screening and screening in special circumstances. And personally, I thought that was a really high number for just a small cohort of clients and over a small period of time. And we had so much depression. And she identified also development disorders, so like things like ADHD. And one of the things which has been explaining to us, for example, is that sometimes clients who have not been adherent to their medication, really they're not adherent because they have another developmental disorder that is actually, that disorder in itself is preventing the individual from processing in the way that we think they are processing the information. All right, is it time? Oh. Okay. And psychiatrists, and as we look again at the HIV continuum, and what their clinical psychologists and psychiatrists are, what their role is in terms of that HIV continuum. So we see some of the things that they do. So they in their counseling, the provision of medication, especially the psychiatric medication, follow-up counseling, very important, and she utilizes telehealth also. Thanks. She uses telehealth also to do some of her follow-up. We are exploring starting a psychologist support group, and that again is to provide to assist the clients, especially those with mental health challenges, because it's going to be more difficult for those clients to remain in care, remain adherent to medication, to HIV medication, and to remain virally suppressed. So these strategies, for example, have follow-up counseling, the support groups, professor administering the psychiatric medication, those ongoing counseling. Put all together, those are strategies. The purpose of those strategies is really for patients, especially experiencing those mental health issues, to have them remain in care, remain adherent to their medication, right, and to remain virally suppressed in the long run. So the psychosocial team, in terms of meeting the needs of virally unsuppressed clients. So right now I've changed focus a little bit, and I just want to focus on that last arrow. So keeping patients virally suppressed. So we say virally suppressed when their viral load, what we're using is less than 50 copies, and in some situations it's less than 1,000. And virally unsuppressed, meaning that their virus is going up. They're not, and this is directly related to medication use, right? So one of the things we know, all of us, I'm sure in the room, no one will acknowledge that issues such that I'm going to list, these things impact on clients' ability to remain virally suppressed. So you have food insecurity, housing insecurity, financial insecurity, mental health issues, medication side effects, non-disclosure, intimate partner violence, substance abuse, stigma and discrimination, lack of support. So the one thing I'm sure we're not going to argue about is that clients who experience these stressors are less likely to remain on medication, completely on medication in the long run. And therefore, they are not able to completely suppress, right? Now, that's where I'm going to just change focus a little bit. I think we can go to the next slide. Let me see. Right. So the psychosocial program as a whole, so just to put it in context, so we started off as a psychosocial as a whole, providing buffering the psychosocial services, putting structure into what was being offered at MRF. And then in order to meet that last arrow, looking at, it says virally suppressed, but what I mean is we know that we have a group of clients in clinic who experience these psychosocial issues, and that these clients are not able to fully suppress, okay? So the psychosocial team was tasked with, and if just excuse me for 1 minute, for 1 second, let me just, right, thanks. So the psychosocial team was tasked with coming up with a strategy that would meet the needs, just like that differentiated care model we were talking about. So what can the psychosocial team do to meet the need of this little group of clients in clinic who have not been able to keep their virus suppressed? After some discussion, we decided, you know what, we can't just repeat the same thing, because if we repeat the same thing we're doing with the general clinic population, we're basically going to get the same results. So we need to do something different. And the lens that we used to determine what we were going to do different was using the background of teamwork. Not to say that services, but making a little adjustment to how we were doing what we were doing, because there's the same staff, the same clients, the same medication. So we have all of those things were the same, and we had to find out what then can we do differently, because you need to do something different. And as I said, you don't do something different, you'll get the same results all over. And that's why when I have teamwork here, and I will explain. So when we tweaked it just a little bit, that's the model now that I will describe that we're using for the clients who are virally unsuppressed. So what we have basically done is that we've come up with a program to meet the needs of these clients. We call it the Enhanced Adherence Support Program, the EASP for short. So the aim of this program is to provide focused psychosocial services and screening for clients who have persistent viremia or whose history of compliance is inconsistent, and therefore their ability to achieve and maintain adherence, and as a consequence, viral suppression is threatened. Now, the statement, it says a lot, but we've actually, so many of the things that we talked about before are actually incorporated inside of there. So when we talk about that focused psychosocial services, again, you have a team. So it's not one person or one service. It's a team of persons coming together. We want clients to achieve and maintain adherence. So using some of the same strategies, as I said, tweaking things a little bit, using some of the same, because we know the issues, we already acknowledge, we know what the issues are, but how do we do things differently? Right? So what we've been able to do in the EASP is to identify clients, especially those who have had persistent viremia. We've been using, as little as a year and back. So it could be a year, 2 years, 3 years, for as long as these patients who have persistent viremia, identifying them, pulling them out, and giving them care in a different setting. We've been fortunate to be able to have a second location, which is over at Scotbush Street, which is a quiet location. So that actually, just the timing of it worked out very well, because what we've done now is that we've put our EASP program in a new location. And like all of us, sometimes like if I sit here at meetings all the time, and then after a year of sitting here, one day I'm asked to sit over there, you feel different. So it's the same thing, so having a different environment sometimes would have a good impact. So what do we do differently at the EASP? We like to think about it like as the ICU of MRF, because for the main part, and it's like the hospital, for the main part, you have clients, like if you have patients throughout the hospital, but you will have a few clients who need ICU care, and you can't give ICU care on Ward 34, right? You have to be in ICU department with dedicated staff, very intensive attention, and working with that client, right? And eventually the client will, step down and go to, and we work that back into how to maintain things after. So from that concept, we think of EASP as providing that ICU care for our clients at MRF who have not been able to be virally suppressed after, a minimum of a year and up. So what are some of the strategies and interventions that we use at the EASP? So one thing that we use is the interdisciplinary team approach, which, yes, we do have at MRF, but we use it in a slightly different way. Now we have a smaller location, dedicated staff, and clearly identified roles of everyone. One of the things that we have learned is that we have that sharing. So sometimes what happens in a big clinic is that the client may be seen by the doctor, who would see the client, record in the notes, for example, identify something, and the patient leaves. When the patient comes back in 3 months and the nurse takes up the file, this is the first time the nurse is actually seeing what the doctor wrote 3 months ago, right? And there may have been something that needs addressing or exploring further. So having one of the strategies that we have found very useful at the EASP is using an interdisciplinary team approach, and having that case management is the one you see that follows. So we have case management. So at the end of this session, what happens is that a client may come to be seen at the EASP. They may be seen by the doctor, the nurse, the peer counselor, and at the end of the sessions, the team would sit together and share information. And that has actually been such an eye-opening experience, because I'll give you an example that we shared. We were all sitting, most of us had seen the client on the day, and when we sat to share, Dr. Boy said, well, the client said, he's not working these days. The social worker said, he said, well, yes, he was just selling something for a small bit of money. He told the peer counselor, something else, that, his family who gives him food and whatever. So he gave all of us a different story. And therefore, when we put it all together, we were like, well, okay, this client is obviously having some challenges, and this is going to be the plan. And together, when we discuss the client, what has been shared with us, we also come up with a more comprehensive plan of care for the client. So the plan of care is not what one person has decided at any one point in time or with gaps in between, but because the team is coming together, the team is coming up with the intervention and the plan going forward, right? We use the enhanced adherence counseling, which some persons might be familiar with. And in the enhanced adherence counseling, it's a structured approach to helping clients who are having problems maintaining adherence. So they are counseled. There's also a scoring tool so that it's an objective way of keeping a check on how the adherence is progressing. It's supported by viral load testing, right? There's a schedule for viral load testing. And a schedule for when the client is seen and how much medication. Usually, with the enhanced adherence counseling, it's that the client is seen, they have that first intervention, they have the assessment intervention, and they are seen at 1 month intervals for 3 months. They have a viral load test done at 3 months, and it's taken from there depending on how the client is progressing and, of course, their viral load. We have structured mental health screening as part of the strategies at the EASP. So all clients are administered the PHQ-9 for depression, and if other challenges are there, the social worker will administer screening tools for anxiety and, for example, substance abuse, which I think are the CAGE and the audit screening tools, so that, again, we're not going by feelings or impressions. We want actual standardized screening tools that gives objective data on this client, and then that can, if you for example 6 months down the line administer the PHQ screen again, you can, for example, compare the two. Has the client made a change, or in which direction, and then determine if there's any intervention, for example, that's needed. One of the important strategies that we're using is co-facilitation. So the concept of co-facilitation is where 2 or more healthcare providers sit with a client and interview the client or have a conversation, including having one with the relative if necessary, so that in co-facilitation that information is shared. And for example, it's a more useful strategy because the client, instead of answering the same question to the doctor, the nurse, the social worker, the psychologist, they can just answer the question once. Having more than one healthcare provider in the room asking the question is also a useful device, because you can pivot on each other, ask the questions in a structured way, and be able to get a wealth of information. We do have our peer support, just as in a general clinic, and because, again, based on the support, we try to have all of our clients interact with our peer so that they gain all the important peer support that the client requires, and as well as the referrals, because we are fortunate to we do the EASP on 2 days a week, a Monday and a Wednesday, and we have this clinical psychologist on site with us on the Mondays. One of the things we have recognized is that a large number of clients who they've made their way, they've been identified to be in the EASP in the first place because they've not been able to be virally suppressed, and we realize that they have a high number of mental health, both diagnosed and previously undiagnosed issues. So we're very fortunate to have the clinical psychologist, and now we do have the support of the psychiatrist. So some of those persons have been started on psychiatric medication. The aim is to stabilize the mental health and help them to be able to adhere. And again, we do have partner testing services on site, as well as one of the additional services is medication pickup. So the clients do have their bloods and medication available to them at the location. Right. Well, this is I'm just going. I think we're just on the last slide, so just bear with me for a few minutes. So one of the things that I was saying that we do look at are the patients and looking at their viral loads over time. So from the 13 clients whom we had their viral loads tested, how many? 4 of them had viral loads. Before they started the EASP, their viral loads were under 1,000. I say sometimes you use 1,000, sometimes you use under 50. And 3 months later, since being enrolled in the EASP, 9 of them achieved viral loads. Their viral loads had fallen under 1,000. And mind you, some of the viral loads that they were starting with, we had a couple that were in the millions and hundreds of thousands. So coming down to under 1,000, that was reason for rejoicing. And we actually were so happy that 6 of the clients were actually able to, after the 3-month mark on the EASP, when you do the 3-month mark, were able to have their viral load under 50. So for all it was early days, we are very much encouraged with the viral load results. And this is one of the ways that we too are going to be measuring the success of the program. So in closing, I think it's just one more slide there.
Right. The mouse is refusing to.
Right. The psychosocial team and the EASP team continue to provide professional, client-focused, quality-driven care to all clients. And we eagerly look forward to our next steps as we build on our foundation as a differentiated program, I should say, as 2 differentiated programs at Medical Research Foundation. I just had my building slide to say thank you. So thank you all very much for your attention, and I hope that we were able to, I was able to, to really to share with you what I call my baby, my 2 babies, I guess it's a twin now, the psychosocial program and the EASP program, really, because I feel so privileged to be able to make a contribution and really to be able, at the end of the day, is what we're doing for our clients. So thank you very much for your attention today.
All right, thanks so much, Sharon, for that comprehensive presentation, and welcome Belinda, who just came with us. So we're a little over time, but if there, we can probably entertain maybe just 1 or 2 questions. So if anyone has any questions they'd like to ask this time, we'll be quite happy to entertain it.